Welcome to the Pain Science Education Podcast, where we discuss ways to treat and reverse persistent pain. I'm your host, Dr. Joe Tatta, a licensed physical therapist and founder of the Integrative Pain Science Institute, where we train practitioners on whole person pain care. This podcast also serves as a public health campaign to support those living with chronic pain. This podcast is for informational purposes only and is not intended to be a substitute for professional medical advice. Hi there. Welcome to this week's episode of the Pain Science Podcast. On today's episode, we're discussing how to bring pain care out of the treatment room and into the community. My guest this week is physical therapist Dr. Sharna Prasad. Sharna takes an integrative, whole person approach to pain care, where she infuses principles of traditional physical therapy along with acceptance and commitment therapy, lifestyle medicine, and pain education. Sharna has done a tremendous amount of work in her home state of Oregon, where she has taken principles of effective multimodal pain management and delivered them through groups and community programs, and has been pivotal in the Oregon Pain Summit. Sharna shares with us her experience going from a staff physical therapist to having her own chronic pain experience and to now delivering these effective principles of care to community groups in her home state of Oregon. So without further ado, let's welcome Sharna and learn about how to deliver community-based pain care. Hi, Dr. Prasad. Thank you for joining me for this first episode of the Pain Science Podcast of 2026.
Yeah, thank you, Joe. I'm so appreciative for you inviting me to this podcast. I come to this place with professional humility more than anything else. So thank you for that.
It's wonderful to have you here. You and I have met occasionally at a national conference, a physical therapy conference or a pain conference. And we have a lot of overlap and a lot of colleagues in common. So I'm very excited to talk to you today about this really interesting, important topic. I know a little bit about you, of course, but I would like to share you with our community here. And we'd all like to know kind of where you came from, what's your background and experience, and how has that influenced the physical therapist you are today?
Yeah, sure. So I was born and raised in India. I came to the US at a young age of 24 to New York City, and I had a bachelor's in physical therapy from India, and I was going to NYU to get my master's. And you know, uh, it was a work study program, and it was quite a struggle because we were broke and coming from India, buying a water bottle was like, oh my goodness, that would be 30 rupees in India. I'm not drinking water. But anyway, it was a great experience living in New York City. I worked at Hospital for Joint Disease, and I was in their pain program. It's an inpatient pain program, which was amazing. And then we moved from New York to North Carolina to South Carolina to Oregon. So I've been in Oregon for the last 27 years and really love the space. I got my doctoral after that, and then I got into pain because I had my own personal experience. So that totally took a head dive into pain science and everything else after that. So that was that's my background.
So our steps have overlapped at some point in New York City.
Must be, must be.
Yeah.
I was there 88 to 92.
Okay. Yep. So I remember the Hospital for Joint Disease very well. It's no longer there, or it's kind of been merged in with another hospital.
Oh,
But
is it? Okay.
wonderful institution. I actually did an affiliation there when I was in physical therapy school. So all of our paths start to overlap after a while. I'm wondering how, or as we start to step into this idea of community pain care, how has your upbringing, your migration to the United States, the culture that you arrived with here to the United States, how has that influenced this idea of community pain care?
Well, I came to the US and in 88, and I had, those were the times when we had phones that didn't have a speaker, and you would hold it in your head, and you would hold it like this the whole time between your ear and your shoulder. And I was very homesick. and didn't realize how homesick I was until I started having severe neck pain. Of course, I have a tendency of not going to see doctors. And because, I'm the physical therapist, I should know what I'm doing. And that was my first episode of pain. And I think I suffered with it for a couple of years and then finally went to a McKenzie course. And in that, I was treated as I was picked as one of the patients with most radicular symptoms and most long lasting pain. And then I became a big fan of McKinsey because I'm talking 88, 89. And that was the time and I got better. So I believed that, oh, McKenzie was the way to treat all my pain patients until 2013, 2015. I had a severe low back pain. And I did not know what was happening. And uh, so that happened. And what it did was it kind of totally took everything I knew about pain, and I didn't know what to do because nothing I knew as a physical therapist was working. And then I got introduced to Dr. Kevin Cuccaro, who was a physician, pain specialist. And he started talking to me about pain, and I wasn't getting it. I just didn't get it. We met once a month for almost a year, and I wasn't getting anything he was saying. So, because I later on figured out what was going on, he was a physician and I didn't think he was part of my tribe. He didn't understand what PTs did until I went to CSM and I'm sitting there with my peers, with PTs, 80,000 PTs, and I heard Adrian Lau, and this was 2016, and he said, "What is pain?" And I was like, "Wait, what is pain?" Oh. And somebody in the audience said, "Pain is about protection." I was like, "No way, pain is about damage. You know that." This is a young PT, he doesn't know any better, and Adrian affirmed him, and that was it was like mind blowing because I was like, "Wait, what do you mean pain is about protection?" And it kind of moved me to my environment as like, who am I? What else is happening around me that could be causing what's happening here? And that's when I realized that I was at that time raising three teenage kids, and the conflict of culture was so big because I was an Indian mom who had this Indian upbringing that Indian kids went to spelling bees and geography bees and robotics, and they became doctors and engineers. And my kids were doing, mini skirts and doing cheerleading and basketball and, leadership things. And I was like very confused. I didn't realize how much of that confusion was causing my pain. And also, I was very frustrated at my work because I was really stressed out, burnt out in my profession. So, that was the starting point culturally as well as professionally. I was in a very dark space at that time and then started my journey in pain science.
Um, in the years that have passed, obviously a lot has transpired. How has your perspective of pain changed? And is it something that you see now as more than just pain is about protection?
Yes, the whole pain world has exploded in my head, and in our literature, right? There's so much going on right now. It's just not, there's protection, there's environment, there's the context, the person sitting in front of us. What is their story? There was this whole explained pain era that we went through that, oh, here's a metaphor, here's the story. Let me pull out these cards and I can show you how pain is. That has all, it's like evolved so much more that it's more in the space of narrative. It's like, what is the patient's narrative and what is the context they're bringing in? And you touched on the culture. It's like, what is the culture that's coming with them? What we're seeing is just a small sliver of their life, and there's so much complexity around that. To be able to respect that and to that humility that comes with doing pain care, as you have talked about so much, that we can, it just humbles you. It humbles you, and it kind of gives you that gratitude that there is someone sitting in front of you who can share their story. And it's such a privilege It is such a privilege to be listening to someone's story and witnessing that. And that is where I think, as clinicians, we need to realize our hierarchy that they're coming, and I work in rural America, complete rural America, where I say 95% of my patients have an education of 12th grade and lower. And how do I know that? I ask that every session of mine because I want to know what kind of material I can give them, what kind of conversation I can have. There is such high neurodiversity. They can't read. There's so much there for yeah, I feel that it's a privilege to be in an environment like that, to learn how complex pain is. And we have just, that cause and effect that, oh, L1, L2, L3, that's why you're having back pain. Let's go and um, remove that disc is so outdated, but we're still doing it. We're still doing it all over. So
There are definitely things we're still doing that are problematic in the world of pain. And if I'm looking into what you're saying, if I'm looking into your practice, what you're saying on some level is person context matters. And I begin with social determinants, like someone's education, because it's going to inform my treatment as the provider. It's going to inform how potentially they may progress or not progress as a patient. And obviously, it's going to impact the therapeutic alliance on some level.
absolutely. The determinants of health. There is an excellent infographic. It's by goinvo.com. They make infographics on healthcare, and they have this infographic. I don't have it right now, but it talks about how 11% of health is impacted by healthcare. I mean, by medical care, and 7% is the environment. 38% is health behaviors, and 21 is socioeconomic, and the rest is genetics and biology. So, of course, trauma informed, right? To understand trauma and what it does to our physiology. It is physiology. We're not just talking trauma out there. So trauma informed care is such a key piece of understanding pain. Social determinants of health is foundational, right? So, I mean, we're 11%. We are medical care people. We have 11% of impact. So there's so many other factors that we have to take into account before we talk pain also, right? So it's complexity. It's so vast. And at the same time, it's very personal. So how do we bring all that we are learning to that individual sitting right in front of us and help them kind of patch their narrative? It's patching their narrative is a large part of what we do.
So as you can tell, I'm laughing and kind of smiling a little bit on this side because it just brings me great joy because the idea that pain is about protection is important. And that may be almost like an icebreaker to a conversation around pain. However, where I currently sit and my current perspectives and the things I'm reading is that we as providers, as patients, as a culture, need to embrace the complexity of what is really happening here and helping people cut through that, like helping people become aware of what that complexity is and then helping them cut through that complexity.
Absolutely.
I'm sure you're aware, our team wrote the PRISM model of pain care a couple of years ago, and it has these 6 domains: person context, physiology, physical activity, pain mindset, pain literacy. Uh, and people have said, well, there's a lot here in this framework or this model. And the response is always the same. There's a lot there because a lot is needed at times to help people, right? Because I think there's a bit of a misnomer, let's be honest. That if I just tell someone hurt doesn't equal harm and pain is about protection, that they get that and something's going to, boom, change in
Hmm.
the nervous system and their pain will go away. And we know that's generally, we've all had our
Hmm.
stories,
Hmm.
success, but that's generally not, it generally takes more than that to help someone overcome pain.
Absolutely. I think the big thing is safety still remains the big part, that how can we help the person sitting next to us feel safer in their narrative, because I think that's key. And the other part is how are we connecting to them? Because if we are connecting to them at a level that they believe that we can guide them through the process, then that's going to take us to wherever they need to go. I mean, the social determinants of health, they have lived. I mean, my patients have very high poverty level. They have lived in that environment, but they're coming in with the belief that my body is broken, right? So we are doing is we're helping reframe, I mean, we're helping them realize that your body is not broken. But the key part is I'm not teaching them anymore. I'm done teaching. I am helping them learn. You
Hmm.
see, there's a big difference because as teaching, we are kind of looking down on people. I'm the teacher, I am giving it to you. But it's the other way around. It's actually they are learning and then they're coming back to you and saying, these are concepts I don't get. So how do we change this? And how do we, move to the, that doesn't make sense to me. I feel I need surgery. I need this. And if that's what it is, then that's what it is. We have to support them in their journey wherever they are, and how do we take it to the next level?
Yeah. And there's a subtlety there that I think we should touch on for a moment that I really appreciate you bringing up. The difference between, let's just call it pain education. I'm teaching someone about pain in the sense that perhaps traditionally that view is almost that it's one way. That person has a deficit in their thinking, and I, as the licensed doctor of PT or whatever you are, psychologist, whoever, have the knowledge that I'm going to impart or teach this patient. How does that differ from a trauma informed perspective? How does that differ from my role is to help facilitate learning as a clinician versus educating?
So I'll tell you how I do it. I do a full assessment evaluation. I call it clinical theater. Literally, it's clinical theater. And while I'm assessing them, I'm putting in words like, wow, you are pretty strong, and not faking it, only if they are. Because most of my patients are very strong, hardworking farmers, hardworking people, but they're in severe pain. It's like, wow, you've got a lot of strength, or your balance is excellent, you're flexible. And then what I say is, I put my hands up, I say, you've got great strength, great flexibility, great balance, great power. But pain is where you're missing things. I have a booklet. Would you? No, then I ask, how are you with reading? Because what we know in health literacy, right? Sixth grade is our health literacy. Uh, you know, so I want to make sure. But even that is difficult for people to do, for some people. So if they say, I don't like to read, I'm like, okay, don't you worry about it. Let's not worry about it. Oregon Pain Guidance, we have videos on pain. Oregon has done a lot of work in pain. Nora Stern has been the leader in that, also a PT. But anyway, I send them to that. It's like, how are you okay watching videos? Or I'll give them a video here or there and help them, tell them that the more effort you're going to put into understanding this and bring it back to me, we can have a discussion, because trauma is in your body, right? So when I am talking to them and my body language is relaxed, I'm in an environment that, has bright windows, and I'm sitting with them, I'm bringing that safety in there, that they're trusting me, that maybe I should look into that. And I give them this option. I said, there's no shooting. If you don't get to it, don't worry about it. You choose what you want to do, because we'll have a lot of time to talk to each other. And we're lucky as PTs. We get 45 minutes to spend with our patients, and not just once, 5 to 6 times. So, you know, I think we are really privileged to be able to doing that work in spite of our reimbursement and our productivity standards and all the other thing. We are in a very good place to help patients.
Let's move this now from the clinic and discuss how did you become involved in bringing your work specifically into the community?
Okay. So this is a very big topic, but I will break it down into three parts. So I did the MAPS class, which was the movement, acceptance and commitment therapy, pain science, and self-compassion. So when my pain got better, I moved my job and I moved to rural America. And this is where I had a very supportive manager, Bob Long, who was also PT, helped me start this group class. And we did 8 weeks. First, we were doing 8 weeks, 2 times a week. We changed that to 12 weeks, and then we brought it back to once a week, 8 weeks. Because of COVID, we realized it was too difficult to do it that frequently. And then I ended up training a couple of therapists also. So they were also running that group class. And we were changing it. It was evolving class. We were changing it based on what we learned. So acceptance and commitment therapy. So we brought those skills in. Lifestyle medicine, we brought those skills in. And so what happened was from that class, yes, this is the best part that came out of it. From that class, there were leaders. So there were a couple of people who took the class over and over again because this was Medicaid and we were the billing for PT for group classes is like $28 per class or something like that. So it's very minimal. So from that class, we got people, leaders that came out from the community who started running what we call a support group. They don't like calling it a support group. They call it an action group. They called it the Marble Jar Action Group. That came from Brene Brown's work, her analogy. So that Marble Jar group, they ended up having a group after the class. As healthcare providers, we had nothing to do with this, but they ran the group in the sense they repeated what we had taught them. They bought courses by different physicians, different people, and they ran it themselves. So that was like, we had empowered the community and the community ran with it. Right. So that was one thing that happened from MAPS class. And the other thing that happened was the Oregon Pain Science Alliance, which is a nonprofit created by the patient for the patients. So what they do is they capture stories of people who have gone through pain and who have done the work and they're feeling so much better. People who were highly addicted to opioids and all that. So they've captured all these stories. They got a grant and they're running it. So these are patient run, nothing to do with healthcare providers. So those were the two big things from the community that came out. Okay, so then the next thing I did, of course, this was, I work part-time. So I work for Samaritan Health Services part-time as an outpatient PT where I do my one-on-one therapy. So the rest of the time, I am constantly looking for opportunities to be involved in the community. So in 2017, I was very interested in the high schools because my kids were at that age. And I said, we can stop this opioid epidemic at the high school level and let's start doing that. Of course, I was single-handedly trying to do this whole thing. So on my days off, I would go into the high schools and spend like 90 minutes talking to the kids. And the kids, oh my goodness, this Gen Z, they were so ready for this information. So this 14-year-old girl tells me, I asked that question, what is pain? And she says, what do you mean, what is pain? Do you mean pain when I twist my ankle playing volleyball, or pain when I have a fight with my boyfriend, or pain when I am bullied on social media? And I was like, oh my God, biopsychosocial. These kids they were so hungry for that. And that's when and I would get these little slips at the end of my talk. What did you get from this? And I have like 300 pieces of that. And I think that's one of the most precious things I have is how quickly in 90 minutes, these kids were picking different aspects of what I was saying. So from that, the teachers came back to me and said, Sharna, we need more. I said, wait, what do you mean you need more? On my days off, I am doing these 90-minute talks and my throat's all tired. So I said, okay. So we applied for a grant and we we worked with the school district to put a curriculum together in their health curriculum on pain and self-care. There's four lesson plans and we trained about 82 people to teachers and teachers aides and whatnot. But we didn't have a sustainability plan. So it's like with all these projects, you learn something. Then we took that curriculum and we brought it into rural to Lebanon where I work. And that's when we got hit by COVID. And that's what made us realize that we needed an online program. And that's when Easy to Care was a curriculum that was created following a grant. And we got a very big grant. We got about $200,000 work on this. And that was a big, huge mushroom that we created. And then we had to curate it and curate it and curate it. So we had a team of about 25 people, healthcare providers, mental health, and community, because it's not about them without them. So, and we had people with different lived experiences, LGBTQ, different socioeconomic variations, different racial variations, age variation. We kind of took into account everything that was important to us, and we put them all in a room, and we provided them with, and they kind of dug into their data and all that, and then they created the curriculum. And that is a highly evidence-based curriculum. So we have layers. So we have a video, which is like 7 minutes to 8 minutes to 30 minutes. The pain one is the biggest. Can you imagine putting all the pain stuff in 30 minutes? And they're little snippets. And then they have resources below that. And then they have research even further deeper. It's up. The whole curriculum is given to them, and then they can go and dig into it as much, or so they're processing this information on their own. The learning, the knowledge is coming in by themselves. But anyway, so that was made for teachers. It was created for teachers because we figured, or at least my thinking was, that if teachers are empowered, then our kids will be. But another failure, it didn't go anywhere because school districts don't have money. The teachers don't have time. It was, the buy-in was not there. So that program just sat. Anyway, so that was the high school level, but I'll tell you how we used it later on. And then the third one was the Oregon Pain Summit. That was very transformational for us in our community, because we started having these, we started bringing in speakers from all over the world. I remember Lorimer Mosley was one of our speakers during COVID time, but we had all kinds of speakers coming over there. And in that process, we had a couple of physicians complete buy into this. And they went into the research and they just became strong pain advocates. Now that was one of the best things that have happened in our community. We have, and some of these physicians are teaching residents. So you see, the chaos theory is when birds flap their wings in Africa, there's a hurricane in Florida, so that's what happened. We kind of did this here and this there, and before you know, it's starting. And so now we have a rheumatologist, Dr. Jonathan Jones. It's the best thing ever. He bought into this. He started understanding this, and he kind of combined it with immunology, so how the immune system is working. So now what we're doing what we call shared medical appointments. So we're taking the Easy to Care curriculum that was created for teachers, because it was quite generic, and it had all the foundations: trauma-informed care, social determinants of health, ACT snippets, and then the lifestyle medicine pillars: nutrition, physical activity, sleep, social connections, stress management, and reduction of substances. So we take that Easy to Care, it's online. We give it to the patients. The patients go, they study this whole thing by themselves, and they're broken down into modules. So they study it, they do the workbook, they come back, and we facilitate the processing and the group activity.
There's so much in there. There's definitely some strategic planning that happened, but then there's also a sense of an organic collaboration that occurred as well at a time when a different way of delivering healthcare and learning was needed during COVID.
Yes. And I don't know about the strategic planning, but in my chaotic brain, I wasn't doing the planning that way. But I kept thinking that if the physicians get it, our community will be richer. And, and they started getting it. And some of the younger clinicians started getting it also. So yes, the change has happened. It's taken its own sweet time, but it's very encouraging.
What's been some of the challenges? Because obviously this is different. It's different than seeing a person one-on-one. It's different than traditional physical therapy. It's different than traditional primary care medicine. It's probably even different than traditional rheumatology. As you mentioned, there's rheumatologists involved. What are the challenges that have arisen from this, obviously starting to port our wisdom?
So some of the biggest challenge I feel are system changes, that the leadership is just not buying into the pain, and for good reason, because if you buy into understanding the way we are talking, a lot of their money would reduce, right? You're no longer sending people for radiology, that many tests. You're not sending them for surgeries, intervention. So I think leadership is one of the biggest thing, and our systems are not ready to do this kind of work. And because the systems are not ready to do this work, our policies are not changing.
I just want to touch on that. I want to touch on that for me. This is an important topic. So when you say our systems, so you're saying when we start to engage in this type of care, there is less, let's just say there's less imaging, there's less medication, there's less other potentially referring around to figure out what the problem is to this mystery illness we call chronic pain.
Mm-hmm.
If I'm following what you're saying, is that there's a financial buffer and change that has to happen into a system because systems are used to taking in money, income, based on all the things that we're saying we should do less of this because it's actually good healthcare, good paying care.
So it's taken me a long time to figure that piece out. What you just said in the last 30 seconds is it's all about the money, right? I mean, I was very altruistic. Oh, it's like, yeah, you do the right thing, do the right thing, do the right thing. But it's about money, right? So unless we understand the money part, we're not going to be able to go beyond that, right? So that part, that reduction in all these expenses, but who cares about the patient? Who cares? The patient is put on the back burner. And that's what patient-centered care becomes, is that we need to put the patient at the forefront. How is the patient getting better? And that is why when we came up with shared medical appointments, that is a win-win-win-win for the system, for the patients, for everyone else. The patient is getting better because they have a community. The physician is billing for 15 to 18 patients. Now, lifestyle medicine, ACLM, is pushing for a higher reimbursement for shared medical appointments. So that part makes it a win-win. The patient's getting better, the physician's loving it. We as our PTs and health coaches or pain coaches, I present myself there as a pain and lifestyle medicine coach with my background as PT, but I'm not billing as PT because if the physician's in the room, we're not billing for that, So that becomes such a big deal. But we're changing patients because we have done shared medical appointments. This is going to be our third cohort starting this week, actually. And Dr. Jones has already told us that their patients have started reducing their medication. 60% of his patients have started reducing their medication. We have an IRB. We're doing qualitative and quantitative research because, unless we put data out,
That's right.
we're not going to be able to change reimbursement. So that's what we're working on right now. It's exciting.
What do you think physical therapy gets wrong when we place the emphasis on one-on-one care that happens in the treatment room versus bringing care to the community?
Well, I think physical therapy is getting a lot of things wrong, and it needs to start at the education level because I think we're still almost practicing Descartes' theories and the pain signals and pain, we're not talking about pain like you and I are talking about. So when we are getting these fresh grads coming out of school and they're put into complex environments like ours, they're just lost. And the next thing I'm seeing that patients, hey, Sharna, this is a very complex patient. I don't know how to treat them. Here's you can work with them. So I think there's a foundational change that needs to happen. I don't know what the answer is. I really don't. I get very frustrated with educational institutes, and that is why I don't participate in that as much, but it's very difficult for me to go that direction
And when you
because
say when you say
nobody's talking. It's hard.
institutions, you're talking about the doctor of physical therapy programs?
Yes, that's
Yeah.
what I'm talking about.
Yeah.
You know what? If I would come out of school and what I know right now and what these students are coming out, I would say I need a refund. I really need a refund. I mean, they are learning basic, and the foundation we have from anatomy, physiology, pathology, kinesiology, exercise physiology, all that is precious. That's great. But how to treat patients with pain, we're missing the mark by a lot, by a lot.
The amount of variation, because I've come across a number of DPT programs in all the different regions of the United States, and the amount of variation that occurs in a DPT curriculum is quite large. And then I believe what we're seeing is that variation winds up carrying over into the clinical experience. And now you have a clinical instructor or a CI, or you're in a residency program even, where there are professionals that have been working for many years, sometimes many decades, and they may be good clinicians, but they're still focusing on, as you mentioned, somewhat of an outdated paradigm to effectively work in a multimodal pain environment. When I say multimodal, I believe it's what you're saying too, is that the physical therapist is delivering the multimodal care.
Exactly.
Yeah. Yeah. So even though we have these, reimbursement system challenges and productivity challenges and scope of practice challenges and education challenges, and you have data on this, obviously, because you have a study on MAPS and you're continuing doing studies, do we have a responsibility as physical therapists to ethically move into this as rapidly as possible?
Absolutely. I think each and every one of us in healthcare has a responsibility to move into this space. And it is absolutely critical because we're not doing that. We are so focused on physical activity and exercises and 3 sets of 10 and here's your handout. It is such a small part of what we can deliver. They have a very big responsibility. So when I came in with pain science was one, ACT was another one, and lifestyle medicine, I give them a menu card or I give them a card that says, these are the 6 pillars of health. And I say, which pillar do you believe at this stage of your life that is going to help you the most in getting better? And it takes them a minute to think about that. Now, they may be a smoker and they may be smoking 2 packs a day. And my clinical understanding is, hey, if you would just stop smoking, your health will be so much better. But I'm not there to give them that. It is up to them to decide that, Sharna, I would like to sleep better. Well, let's talk about sleep. So I customize it to their needs in the individual session. But in the group sessions, we are so we take each module, right? So we take each health pillar and they are given enough physiology and pathology of what's going on through the videos. Then they're coming back and saying, well, what do we think we should do? And the answer is, what do you think you should do?
Mm-hmm.
And then they write down the 3 things that they think they can do to improve their health. So you see, it's gone from the teaching to the learning. So they're processing it themselves rather than we telling them, or they're listening to their peers. And that's why the bigger groups work really well, because they're listening to their peers and they're saying, she did that. She stopped smoking and that helped her. Maybe I should think about that. So then they're in their contemplative stage, then they're thinking, how can I do that? So it's very powerful. It's very powerful.
I love the idea of peer collective. Obviously, it reinforces what we're talking about here today. There's also a process in the PRISM model of pain management that we specifically put in there, which is called peer collective, and how important that is. And obviously, all your work, really kind of encompasses that in some way. You mentioned like 3 critical areas that, you have brought this development and this work into. Which one do you think has had the biggest return on investment?
I would say the Organ Pain Summit, because that changed so many doctors. I won't say so many doctors, but a handful of doctors. But because they are now working with residents, I think we have started a wave of change that is starting there, and they are very trauma informed and all that. So I would say Organ Pain Summit. And then the second one was the Easy to Care curriculum, which now we're using as shared medical appointments, which is also very, so the health systems, the organizers, the directors, the medical directors are now curious to say, wait, you're increasing RVUs, the physicians are more productive. How are you doing that? And the patients are getting better. How is this a win-win place? So that has really picked up quite a bit of momentum right now.
Sharna, you have decades of experience in applying a biopsychosocial model of pain. And when I say a biopsychosocial model of pain, I want all of our listeners to understand that means more than just fear. It means more than just hurt equals harm. Sometimes things change slower than we'd like it to happen. And practitioners, including me, it took me a while to really say, I'm going to do this. I don't care if it takes me a couple of years to learn something new. I don't care if I have to read books. I don't care if I have to expand my scope, if my scope has to become permeable. I don't care if I even slightly go beyond my scope, as long as I'm doing it safely
Mhm.
and I'm getting good outcomes and the patient is safe and they're happy. What would you say to a physical therapist or maybe even another, health provider, how to start to really change who they are as a professional and move into this space because it's really the only space that there is at this point?
I, so one of my biggest things I talk about is self-care before service. That therapists need to learn how to take care of themselves first before they apply to service, because otherwise we're just going to burn out. I mean, what our attrition is, 7 years, and we're leaving the profession. I mean, that's a very big part of what's happening to PTs, right? So if they keep doing this biomechanical training that they've had, they're coming out of school with that kind of training. And, like you said, you're exposed to more schools than I am, but the ones I am exposed to, I am quite frustrated with the fact that they're coming not understanding they have good communication skills, but they don't understand all the trauma informed care, social determinants of health, and all the other parts that you and I discussed in that. So to a young clinician, I would say that learn to take care of yourself in a very holistic manner first. And then once you get that, then expand. The PT training you have is enough. When you take courses, don't go and learn new manual skills, because that's what I see. I see these clinicians sitting in the room watching videos of new manual skills. It's like, that is nothing. Go into behavioral health, go into lifestyle medicine, go take some Joe Tata's courses that are way more organized than, anyone else. I mean, I am teaching a 2-day course coming up end of January for my local community, because the therapist in my clinic came to me and said, Sharna, we need help. And I was like, I can't keep taking your patients. We got to do something bigger. So I'm doing that. And then I put in 3 months of mentoring as part of that course. But again, the same thing. They have to do some studying before they come to the course, because they need to have a foundation. So yeah, I don't know. I don't have the answers, Joe. There's so much that you're doing, which is so awesome. But I'm doing my share in my community, but I can't do what you're doing. And that's why it takes all of us to do what we're doing.
It does take all of us to make a significant change like this. And I appreciate you joining me this week to discuss about this topic of how we can really translate the skills that we're using in the treatment room into the clinic. Instead of helping one, we help many. And I really believe when we help many, we provide the type of healing that our communities and in some way our country and even our globe needs in lots of different ways. So I thank you for being here with us this week and for sharing your experience and your knowledge and your wisdom with all of us. If people would like to learn more about the work you're doing, how can they reach out to you?
Well, I have a website, which is Solace, SOL4CE, number 4, that is like to bring solace into the world. And it also is soul force. So it's you're activating the soul's force. So yeah, it's my website and you can just reach out to me through that. I have a Facebook page, professional Facebook page, which I'm not very active on, but it says Dr. Sharna Prasad. I'm also on LinkedIn with the same name and it's Sharna Prasad. And I'm not big on Instagram or Twitter or any of that. So, but email works really good for me. So it's sharnaprasad@gmail.com. So I would love to hear from you if there's any help you need, or if you want to create a community in your community. I've done that. I've done a lot of it. I would love for you to learn from my mistakes and I can guide you through that process. And I'm happy to do that because, I love doing this kind of stuff.
I will, of course, share those links, both Dr. Prasad's website as well as her email address on the blog. And you can find that blog over at the Integrative Pain Science Institute.com. Just go over to podcast and you'll find both an audio, a video, as well as some transcribed portions of today's episode there. Thank you for joining us this week. Please make sure that you share this episode with your friends and family on your favorite social media channel. Make sure you follow us on your favorite podcast channel as well as YouTube, and leave us a 5-star review if you can, as we move into 2026 with this really important message of obviously delivering the most optimized pain care we can possibly deliver, whether that's individual or whether it's for the community. I'm Dr. Joe Tatta. Thank you for joining us, and we'll see you next week. Thank you for listening to the Pain Science Education Podcast. To subscribe to the podcast and learn more, visit integrativepainscienceinstitute.com. That's integrativepainscienceinstitute.com. Sign up to receive weekly updates and learn about our continuing education courses. If you enjoyed this episode, leave us a review on your favorite podcast platform and share this episode with your friends. Please join us next week as we share more science-backed solutions for treating and reversing chronic and persistent pain.